we have different tests to early diagnose and confirm formation or early detection of cervical CA. And the earliest routinary procedure that's usually done to determine early formation of cervical CA is always Pap smear. So Pap smear is an early way of detecting growth into the cervical tissues, or a way of detecting early formation of cancerous cells on the cervical structure of your patient. Now, again, Pap smear is advised at the age of 21-year-old, or if you have been sexually active for 3 years. If you have been sexually active for 3 years, then you should be having Pap smear, whichever comes first. So at the age of 21, or if you have been if you are sexually active for 3 years, then that's the time that you have to have a Pap smear. Now, what else? Certain things that you have to advise in Pap smear: it is best done before, or it has best done 10 days after menstruation. It has to be 10 days after menstruation, and days prior to the procedure, 2 to 3 days prior to the procedure. What is it that they have to prevent? Avoid? Okay, it has to be no sexual activity, no suppositories, no any vaginal medication, no vaginal douching should be done prior to the procedure. Again, Pap smear is advised if you are more than 21-year-old or has been sexually active for 3 years. It is best done 10 days after menstruation. And it's done, if you're about to have Pap smear, you should prevent sexual activity, vaginal suppository, or vaginal douching 2 to 3 days prior to the procedure. Now, how often do you have to do your Pap smear? It has to be done annually. So it has to be annually. It has to be done annually. Once you start having Pap smear, it has to be done annually. But if the result shows shows a positive result, it has to be repeated in. If it needs to be repeated, it has to be repeated in 6 months. It has to be repeated in 6 months. So if you are actually having a possible diagnosis, the Pap smear should be repeated in 6 months. Now, what will be the diagnosis? You might be diagnosed as class 1, class 2, class 3, class 4, or class 5. You might be diagnosed as class 1, class 2, class 3, class 4, class 5. So the diagnosis on the Pap smear will help a patient in determining what's going to be the next step. If you're diagnosed with class 1, you're considered negative. In short, there's no metastatic cell or there's no hyperplasic cell that has been identified. In short, you're okay. So if you're class 1, diagnosed with class 1, then what will be your advice to your patient? You have to come back next year for another Pap smear. So you just have to come back next year for another Pap smear. Now, if it's class 2, they are seeing some inflammatory response. This is a probably positive. This could be probably positive or probably an infection. This could be probably positive. It could be a infection. Probably positive, it can be an infection. So if it's probably positive and the inflammatory response, the hyperplasic cells that was seen was just an infection, then what do you need to do? You have to come back after 6 months. So after 6 months, you have to come back, but during right after the Pap smear, you will be receiving antibiotic therapy. So you will be receiving treatment for infection during right after that Pap smear. So after the treatment of the antibiotic, supposedly when you come back, you have to be negative already. So again, if it's class 2, you're probably positive, probably caused by infection. So what the doctor needs to do, treat the infection, and after 6 months, you have to go back to the negative result. Now, class 3 is a symptom wherein you are actually suspicious. This is a suspicious but not conclusive. There is a suspicion but not conclusive. So there is already a suspicion on the findings in your cervix. So if there is a suspicion, then you have to rule out everything. So again, you have to come back after 6 months. You have to treat because it might just be an advanced case of an infection. But since there is suspicion, you have to further investigate. And to further investigate, you have to visually directly examine the cervix with the use of colposcopy. So if it's class 3, then you are suspicious but not yet conclusive. There's a high suspicion but there's not yet the conclusion. So what you need to do, directly visualize the vagina or the cervix with the use of colposcopy, have some treatment of antibiotic, and you should go back after 6 months. Hopefully it would be negative. Now, if it's class 4, it's highly suspicious. It's highly suspicious. Now, if it's highly suspicious, then you are actually seeing a hyperplasic cell. So what you need to do is, of course, you have to have the test repeated in 6 months. You have to treat a possible infection that might have caused excessive inflammatory response. You also need to have a direct visualization of your vagina, of your cervix, but since there is a high suspicion of metastasis, then we have to do we have to confirm this suspicion. How do we confirm the suspicion? So at this time, since there is high suspicion, you have to have biopsies already. So you have to have biopsy. After cervical biopsy, it is expected for patient to have periods of bleeding right after the biopsy. So class 4 is highly suspicious. So and then you have to come back after 6 months. You have to give antibiotic therapy. You have to do direct visualization with colposcopy and biopsy. Now, if the patient had cervical biopsy, it is expected for them to have bleeding right after the biopsy, just because the cervix has been irritated, so it's expected for them to bleed. That's highly suspicious. Now, if you are diagnosed with class 5, this is conclusive. This is conclusive already. Now, if it's conclusive, then this is already malignancy. Now, if it's class 5, it has already spread out. So the biopsy showed probably it's already positive. So if it's malignancy, you still have to come back after 6 months for further evaluation. Antibiotic might still need to be done. Colposcopy is still done to your patient. Biopsy has confirmed the metastasis, and since it has confirmed the metastasis, then we have to take out that part of the cervix that has the metastatic tissue to prevent spread to the surrounding tissue. So to remove that, we have to remove a cone-shaped part of the cervix, and what do you call that? Removal, surgical removal of that part of your cervix, that your coni or conization. So at this time, you have to have an immediate surgical management to your patient. So again, class 1, conization, removal of a cone-shaped part of the cervix. So class 1 is negative, you just have to come back annually. Class 2 is probably positive due to infection. So what you need to do? Treat the infection with antibiotic, be back in 6 months. Hopefully, you'll go to negative. If it's class 3, it's suspicious but not yet conclusive. So if it's not conclusive, we have to see it. To see it, you have to visually examine the cervix with the use of colposcopy. Now, of course, we would still have to consider infection, so we have to give antibiotic, and after 6 months, you have to go back so that you, hopefully, you will go down to the lesser class. If it's class 4, it's highly suspicious. So if it's highly suspicious, then we have to find out if it's metastatic. So how do we find out? It's biopsy. To perform biopsy, of course, you need to directly visualize the cervix with the use of colposcopy. Antibiotic is still given, and 6 months after, you have to come back for further evaluation. Class 5 is conclusive. This means that the biopsy was positive. So if it was positive, there's nothing else that we have to do. We have to rapidly take out the cancerous cells in that cervix by taking out a cone-shaped part of the cervix, and that is your conization. Your conization is, of course, being done because of the basis of your biopsy, colposcopy. Antibiotics are still given, and after 6 months, you still have to be evaluated. Now, if after 6 months you were negative already, when is the next time that you're going to come back? If after 6 months you were negative already, when's the next time you're going to come back? After 6 months. And then how many negative exams do you need? It has to be 2 to 3 negative exam. It's actually 2 to 3 negative exam. 2 negative exam will cause your patient, will let your patient come back after in 1 year. So it has to be 2 to 3 negative exam. It depends on the hospital policy. 2 to 3 negative exam is enough for you to come back after in an annual basis. So that's your pap smear. So this is routinely done to early diagnose your patient who is suffering from cervical DCA. So this is the earliest way in treating cervical CA. Now, If the patient has cervical CA, conization is done, but certain other procedure that can be done to your patient. What are the other ways of managing your patient who has cervical CA? First is you can perform electrocautery. Electrocautery. This is the use of heat to destroy the cancerous cells. Use of heat to destroy the cancerous cells. So just like how you want your warts to be removed from your face, that is the same thing. You will electrocauterize that part of the cervix that has cancer formation. Hopefully that heat would destroy the cancerous cell. If it's not heat, then you can actually use the cryotherapy. The cryotherapy uses excessively cold environment to destroy the cancer cells. Cryotherapy uses makes an excessively cold environment, expose it to the cancer cells. Hopefully, the cancer cells will die. A more innovative one or a more advanced technology that is being done right now is the laser therapy. So the laser itself is the one that will kill the cancerous cells. So exposure to light with laser would usually try to destroy the cancer cells. So from the word itself, the laser is the one that will try to destroy the cancer cells. These are usually advised if you are diagnosed on the early stage. But if you go to the latter stage, sometimes you might be benefiting from therapies, radiation therapy and chemotherapy. So this will be done if you are just on the early stage of the cervical cancer. Early stage of the cervical cancer, this might be done, but on the later stage, you need to undergo different therapy. Now, first, you can have the surgery. So surgical removal of the uterus can be done so that it will prevent spread of the cancer cells. Now after surgery, your patient might be undergoing chemotherapy to destroy any cancerous cells that could probably spread to the surrounding tissues. And what else? They can perform radiation therapy. Now, in radiation therapy, it has now an advanced advanced measure wherein the radiation will just expose a part of the cervix. You call that your brachytherapy. This is your brachy-radiation therapy. Now, it's an implant that is placed near the cervix, and this implant will emit radiation to the cervix to kill that area of the cervix that is having cancer formation. So these are actually gadgets that is internally placed that will start to emit radiation to the cervix. These are actually equipments, or the brachytherapy is actually an implant placed near the cervix that will emit radiation that will try to kill the cancerous cells. It will stay there for 2 to 3 days. That's brachytherapy. Yes.
When they do chemotherapy, they just give them medication?
Yes, medicine. No, chemotherapy is just medication per IV or medication shots, IM, that is given to your patient just to suppress cell production. Radiation therapy is killing of the cells. Now, one way of performing radiation therapy is brachytherapy, wherein an implant, it's like the lead of the pencil. You know the pencil? The lead of the pencil. It's just that size that is placed near the cervix for 2 to 3 days, and that lead will start emitting radiation to the cervix that will try to kill the cervix. So in short, this patient needs to be on bed rest, most of the time hospitalized. Now, it can be brachytherapy, and the implant will be placed in 2 to 3 days. It will try to damage the cancerous cells. Now, one more thing that can be done will be the external radiation. It can be done is the external radiation. Same principle. You will be exposing the cervix into radiation, but this time it's just done once a day. So it will be done once a day for 5 days for 1 week. It should be done 5 days a week for several weeks until the patient has a better outcome on the pap smear. So again, external radiation is a different way wherein you will use a probe, you will expose the cervix, try to kill the cancer cells, and the patient is advised to come to the hospital for 5 days in 1 week. This will be done based on the prognosis of the patient. This will be continuously done based on the prognosis of the patient. Now, what's the difference between external and brachytherapy? External damages more healthy tissue. Brachytherapy damages less healthy tissue because the external radiation therapy exposes even the healthy tissue. Brachytherapy is just placed on the area where there is a suspicion of cancer formation. Now, what are the things that you have to tell your patient? If the patient is on brachytherapy, most of the time they are advised to be hospitalized. Why? They have to be bedridden. Why? The implant is on their cervix. So they should not be walking around to prevent the implant from falling off. If they need to go to the bathroom and pee, they have to flush the toilet twice. They have to flush the toilet twice. Why? Because if they pee, there is a tendency that the radiation will also come out, and if somebody will be using that one, that person might have the radiation as well. So if a patient is on brachytherapy, you never allow a woman suspecting pregnancy because the radiation can affect the pregnancy or the fetus inside the mommy. So again, in brachytherapy, you never allow a person who is suspecting pregnancy to visit this patient because the radiation is actually can be emitted and she can harm the baby inside. So in short, the patient ideally should use his or her own bathroom. He has to have his own restroom. Why? Because of the emission of radiation. Now, you tell your patient, if some of the implants falls in the floor, if it falls in the floor, what do you need to tell them? Never pick it up with their hands. They have to use a long forceps. So they have to use a long forceps. So what should be at the bedside of a patient who is on brachytherapy? A long forceps. Now, the long forceps prevents direct contact with the skin because it can cause radiation to the skin. So again, brachytherapy is the internally placed implants that will radiate to the cervix. Certain things that you have to consider. First, ideally, they have to have their own restroom. If they're sharing restroom, whenever they use the bathroom, they have to flush it twice. If there is visitors coming, never allow anybody who is suspecting pregnancy. So what is it in the question? NCLEX, the choice in the NCLEX that I saw was a patient, who would you allow to visit? Is it the grandmother who was just recently discharged for pneumonia? The second is a teenager with her younger sister. The third was the sister of the patient who just got recently married, and the fourth was like an uncle or something. So of all of those four, you have to select the one who just got recently married. Yeah, because that is the one who is probably positive for pregnancy. So this is the one that you should not allow from your patient. So that's your brachytherapy. ATI?
Yeah, pregnancy. Yeah, remember?
We did the first module, and she talked about how you have to have.
It was 3 questions, yeah.
But you have to remember, they talked about how you have. Yeah, it really doesn't, and she talked about how you have to have the radiation department, so that if it falls out, the radiation department
You
has
cannot
to be.
touch
Yeah,
So
it
that
has to be the long
touch it,
forceps,
no
yeah.
touch it, you
Mhm.
with the stuff that the radiation department actually
And
comes
let
in and
physician
feels
know
the
about
function.
that.
Yeah. Well, it depends on the hospital protocol. For some nurses, for some onco nurses, they can just pick it up themselves. They have to it just have to be the proper disposal. You just don't throw it on the trash can. You just have to pick it up and then you have to place it in the proper disposal.
And is it true that the nurses cannot stay long enough?
Yeah, you usually have to have a shield 6 feet away from the patient. It has to be a limited space. We have to use as X-ray shield when you're going to that patient. Even those who are taking RAIU, the radioactive iodine uptake test, they have to drink a radioactive iodine for thyroids. So they're actually also emitting radiation. So when you go there, it has to be on a limited time because you are exposing yourself also.
Time has contact with the patient, have to document how long in the boxes. They have to document how long.
Yeah, just for proper timing of how long you're because there's I just can't remember the specific number of hours that you can just be exposed for that shift. If you're exceeding that, I don't know if it's 2 hours or 3 hours, there's just a specific number of hours that you can allow yourself be exposed to that type of radiation. Okay, So they say that if it's X-ray radiation, you always have to be 6 feet away. So you just imagine a 6-footer guy. You just imagine him laying down. That's how far you should be from X-rays. Okay? So that will be your radiation therapy. Now let's go to your cancer of the endometrium. Cancer of the endometrium is cancer of the uterus. Cancer of the endometrium is the cancer of the uterus. Now, in cancer of the uterus, all you will have is just an excessive menstrual bleeding, excessive bleeding during menstruation and in between menses. So the symptoms that you will only have in cancer of the endometrium will be menorrhagia and metrorrhagia. But if it's, of course, an overgrowth, behaves like a tissue, and if the tissue bleeds, the cancer cells also bleeds. Now, as the cancer cells increases in size, of course, it will compress surrounding nerves, so you will have pain. As the cancer cells increase in size, then it will cause you the feeling of heaviness or fullness. As the cancer cells increase in size, this will cause now a abdominal mass that is palpable to examination. So once your patient is having cancer of the endometrium, on the early stage, your patient will be complaining, when I bleed a lot. And when I had menstruation, it's like I'm having every week. Now, it's because they are having menorrhagia and metrorrhagia. Why? The overgrowing cells behaves like a normal tissue during the menstrual cycle. Now, if this patient would have excessive enlargement of that mass, then they will now have compression of the surrounding nerve causing abdominal pressure resulting to pain. They will also, since there is an increasing size of the mass, they will have the pelvic heaviness or pelvic fullness. And since the mass is increasing in size, it will start to become palpable. In short, your patient will have an increased abdominal girth. Now, it usually happens to women who are postmenopausal. It usually happens to women who are postmenopausal. Now, what are the stages of cancer of the uterus? You have your stage 1, stage 2, stage 3, stage 4. If it's stage 1, it just affects the uterus. If it's just stage 1, it just affects the uterus. If it's stage 2, it affects the entire uterus, including the cervix. So if it's stage 1, it's just like in situ, a part of the uterus. If it's stage 2, the entire part of the uterus, including the lowest part of the uterus, which is the cervix. Now, if it's stage 3, it is on the uterus, spreading to the pelvic region. Spreading to the pelvic region. So what are pelvic organs? Your ovaries and your fallopian tube. So if it's extending to the pelvic organ, then that is stage 3. If it's stage 4, it's a metastatic type. In short, it's not just in the pelvic organ. It might have metastasized to the GI system, to the lungs, to the brain. It might have metastasized to the urinary system. So if it has spread to the lymphatic tissue, lymphatic node, that is already stage 4. So stage 1 is just on the uterus. Stage 2 is uterus and entire cervix. Stage 3 will be going to the pelvic organ, which involves the ovaries and the fallopian tube. Stage 4 is that it has metastasized to a different system. Now, how do we diagnose your patient if the patient is having cancer of the endometrium? It's again, of course, the biopsy to your patient. Now, it is, of course, biopsy on your patient. So you have to perform biopsy so that you will be able to determine if there is cancer formation to your patient. Now, what's the management? If uterus develops cancer, there's only one management that is best actually done. It has to be surgery. Now, why does it have to be surgery? Uterus is highly vascular. So if it's highly vascular, it can send cancerous cell to the different parts of the body. So you have to rapidly stop that one, quickly stop that one, to prevent rapid spread of metastasis. So you have to perform surgery. If you will be removing the uterus, you call that your hysterectomy. But once a patient develops endometrial cancer, most of the time, it has already spread before it was diagnosed. So even without doing biopsy of the surrounding structure is advised to be removed to prevent a possible spread. So if you are on a stage 1, even on a stage 1, the advice will be perform tabiso in your patient. What is tabiso? Total abdominal hysterectomy with bilateral salpingo-oophorectomy, and it's in your slide. Total abdominal hysterectomy with bilateral salpingo-oophorectomy. So what have you removed?
Ovaries too?
Yes. So you have to remove the uterus, you have to remove the bilateral fallopian tube, and you have to remove the bilateral ovaries. Why? Again, because of the vascularity of the uterus, cancer cells rapidly spread. So even if the biopsy doesn't show any cancer cells migrating to the fallopian tube, it is best advised to remove that as well because of the vascularity of the uterus. So stage 1, they are advised to have the tabiso already. Now, if it's stage 2, tabiso is advised, but it will not end there. Since the entire uterus is affected, extending down to the cervix, they might also benefit from radiation therapy. So after tabiso, they have to perform radiation therapy to completely dissolve cancerous cells that has formed. Now, in stage 3 and stage 4, it depends to what extent it had occurred. So it depends. So in short, it depends if the patient has still a good prognosis or a bad prognosis. So uterus and third and fourth stage, the doctor needs to determine what is the extent of the damage. So that's stage 1, 2, 3, and 4. Now, whenever your patient had radiation therapy, what's your concern? It has to be the skin integrity. If the patient is having radiation therapy, then of course, do not expose them to sunlight. What if it's chemotherapy? What if the patient is undergoing chemotherapy? So again, patient might have surgery, patient might have chemotherapy, and the patient might have radiation therapy. Radiation therapy, what's your concern? It has to be the skin integrity. Never ever allow your patient to be exposed to sunlight because this might cause burning sensation. If it's surgery, of course, the self-esteem of your patient, body image of a disturbance of your patient. Remember, if a reproductive gland has been removed, you're like a man already. You have removed the organ of the women, so they feel like less of a female. So self-esteem is your concern if it's surgery. Knowledge, health education should be informed to your patient. You will not anymore ovulate, you will not anymore menstruate, you will not have any babies anymore. Now, if it's chemotherapy, what's your concern? Again, WBC, RBC, the platelets will all decrease. What do you call that?
Or it's going to be
Pancytopenia.
Okay, that's your pancytopenia. Watch out for bleeding, watch out for infection, and watch out for anemia. Pancytopenia alert on your patient. Watch out for bleeding, watch out for anemia, and watch out for infection risk of your patient. What else? Chemotherapy can cause excessive dryness of the mouth. So if it's excessive dryness of the mouth, you lose the enzyme, you lose your saliva. The saliva prevents growth of microorganisms. So what will happen? The mouth becomes dry. Candida albicans is in the mouth. Once it's dry, it easily cracks. If it cracks, Candida albicans go inside. If it goes inside, then it becomes infected. So what is the call that infection, inflammation of the mouth is?
No.
Stomatitis.
Okay, that is your stomatitis. Okay, again. Chemotherapy can cause excessive dryness of the mouth. So stomatitis can cause, chemotherapy can cause excessive dryness of the mouth. So if the mouth gets dry, so your saliva is not produced, saliva contains enzyme that controls growth of microorganism. So if your mouth is dry, it easily cracks, microorganism starts to go inside your mouth. So if it goes inside your mouth, what will happen? It will start to perform an inflammatory response, so you would have stomatitis. Just to make a difference, our mouth is dirty, but our mouth is not always infected because our mouth have enzyme. Just to compare, which is cleaner, the mouth or the nose?
No.
Oh, let me see. Which is cleaner, the mouth or the nose?
No.
At this point in your life, which is cleaner, the mouth or the nose?
No. I don't think it's all.
Which is cleaner, the mouth or the nose? It's actually our nose.
No.
Why nose? Because the nose has protective mechanism. It has cilia. Remember the respiratory system? It has cilia. It has a broom inside that whenever something's trying to get inside, it wipes it away with the use of Sneezing. Now, our mouth is dirty. A lot of microorganisms in your mouth because there are things that you put inside your mouth that should never be actually placed inside your mouth, right? That makes it dirty. But what helps your mouth prevent itself from having infection? It's because of the saliva. So mouth is cleaner. Mouth is dirtier than the nose in adult. So that's why if you're gonna suction an adult, where do you start first? What do you start first? Is it on the nose or on the mouth? What do you suction first? Nose or mouth? Clean first, it has to be nose first. Clean first, it has to be the nose. When you're suctioning, since nose is cleaner than the mouth, the first thing that you need to suction is nose, followed by the mouth. That is for the adult. But for kids, less than 3 months, what's the first thing that you need to suction? It has to be the mouth. Why? Because babies are nasal breathers. The only way for them to breathe is through their nose. So again, in babies less than 3 months, the first area that you need to suction will be the mouth. Why mouth? Because babies are nasal breather. The only way they know how to breathe is through their nose. So once you occlude this one on them, they will not breathe through their mouth. And compared to us as adults, when I close your mouth, how do you breathe? You breathe through your nose. When I pinch your nose, how do you breathe? You breathe through your mouth. In babies, no. They don't know that mouth can also be an airway. There can also be an access for airway. So that's why babies are at risk of suffocations. Babies are at risk of decreased oxygenation because of the lesser ability to breathe through their mouth. So that's the thing. If you still remember, you're floating in an amniotic fluid inside your mommy. Once you go out, you cut the cord. Before you let the baby cry, you have to suction the mouth. Before you let the baby cry, you have to suction the mouth. Because when they cry, all the amniotic fluid on their mouth will start to get inside, and that will cause aspiration to the babies. Right? After the baby is born, suction the mouth because babies are nasal breather. Now, when you suction the mouth of the baby, are you taking out the amniotic fluid? Yes. Where will they breathe? Through their nose. But after you suction the mouth, you still have to suction the nose in babies. Yes. If you suction the nose, where will they breathe?
They won't.
No more, right? Because they cannot use their mouth. So if they don't breathe, what do? Gasping reflex. Try to cover both of your mouth and nose. What will happen? If you run out of air, you will start to do the gasping reflex. So in babies, same thing will happen. You suction the mouth, they breathe through their nose. But if you suction the nose, they don't know how to breathe anymore, so what will they do? Gasping reflex. So before you suction the nose, make sure that the mouth is empty of any content. In babies less than 3 months, you have to empty the mouth of any content before you suction the nose because they will tend to have the gasping reflex. Okay? So again, stomatitis is a risk. It's because of the dirtiness of the mouth. So you have to give what? To prevent excessive dryness of the mouth, to handle stomatitis, what can you give to your patient who is on this chemotherapy? Ice chips to your patient to keep the mouth moist. To lesser the sensitivity, to lesser the inflammatory response, ice chips can be given to your patient. Can you give orange juice with ice? No. Lemon juice with ice? No. You will hurt your patient because of the acidity of the juice. So again, stomatitis, ice chips. What else? If your patient is undergoing chemotherapy, you will not just kill bad cells. You will also kill good cells. Your hair start to fall. Yes. Will the hair start to get brittle? Yes. So if hair starts to fall, they will suffer from body image disturbance because of alopecia. So that's because of the alopecia. So if there's alopecia, what do you need to advise your patient? Temporary use. This is just temporary, so you might want to use wigs. You might want to use bandanas. So wigs and bandanas can be advised to your patient. And since alopecia is just temporary, don't worry, your hair will grow back once you stop having the chemotherapy. So this will be the therapy for your patient who suffers from hysterectomy. Now, there are just 2 types, or cancer of the uterus. There's just 2 types of performing, there are just several types of performing hysterectomy. Total hysterectomy means you will be removing the uterus, including the cervix. Again, what are the 3 major parts of your uterus? Cervix, fundus, and
body.
body, the corpus of the uterus. Which of these three is the one that performs contraction?
Fundus.
Fundus. What causes a uterus to contract?
It's a
What is that?
Ah,
That
no,
is
no,
that
no.
hormone that
Hormone
causes
is
the uterus to contract. Fundus of the uterus to contract.
Oxytocin.
Oxytocin, right? That's your oxytocin. What are the ways to release the oxytocin?
It's a pituitary.
Pituitary gland through nipple stimulation. You can also give that through medication. Now, body is the one that encases the baby. So that's the one that stretches when the baby is growing. Cervix is the one that opens when the baby is about to be delivered. It has to be closed when the baby is still premature. It has to be slowly opening when the baby is due. So the cervix is the one that you will be hearing when you are in labor. Oh, she's 2 cm dilated. She's 3 cm dilated. It's the opening of your cervix. Once you're 10 cm dilated, the head is the space is big enough for the head to come out. What you need to do, push that cervix. How do you push that cervix? Let the woman walk. If they walk, they are pushing the cervix down. If they're pushing the cervix down, then you're pushing the cervix to open. So if you're on a 2 cm, 3 cm, 4 cm, what do you advise the patient? Ambulate. But of course, 10 cm, you just advise the patient to push because this is the best time for the baby to be expelled. Now, if you will be removing the uterus and the cervix, then you will be doing total hysterectomy. If you will be removing the surrounding organ, then you will be doing tabiso, removal of the uterus, fallopian tube, and ovaries. Now, if you will be removing including the lymph nodes that connects to your uterus, then that will be radical hysterectomy. Why do we have to remove the lymph nodes on the pelvic region?
Because lymph node is going, because lymph node it's cleaning all system. That's why all going through the lymph nodes and the first affecting lymph
Okay,
node, that's
it's,
why you have
yeah, very good. The lymph nodes is the one that will try to deliver all this waste product to the different parts of the body. Now, as a lymph node, it tends to filter out. Lymph nodes filter out. The lymphatic system is the one that filters out any drainage in our body. Anything draining in your brain, microorganism, waste product, foreign object, it drains to the lymphatic system. Anything draining from the liver that cannot be excreted, it drains to the lymphatic system. Now, as it drains to the lymphatic system, you have the lymph nodes. When it hits the lymph node, what does the lymph node do? The lymph node filters it. So all microorganism, all foreign substances get stuck on the lymph node. So what will happen? Some other will go to the lymphatic vein. Now, and then the lymph node will try to eliminate that waste product. Now, the problem is cancer cells doesn't get filtered in the lymphatic node. It doesn't get stuck on the lymphatic node. In short, it just passes the filtration and goes around to the different parts of the body. So if it goes around to the different parts of the body, then you will be spreading the cancer cells. That's why you have to prevent this by taking out the nodes that is found on the uterus of your patient or the pelvic region of your patient. So that's radical hysterectomy. Vaginal hysterectomy is once the uterus is removed through the vagina. In short, what's the position of your patient who will have vaginal hysterectomy? Lithotomy position. So lithotomy position, legs flex, so you will be cutting the uterus through the vagina. What type of disorder can a patient would you advise vaginal hysterectomy to be done? Prolapse, the uterine prolapse. So they are the one who would usually have this one, vaginal hysterectomy. Now, abdominal hysterectomy is the most common procedure done to a patient who has uterine CA. Abdominal hysterectomy is the most common type of surgery that is usually advised, abdominal surgery, wherein they will have an incision on the abdomen, try to take out anything that they have to take out. Now, if it's abdominal incision, certain things that you have to remember post-op, what is expected on your patient? If you have removed the uterus post-op, what should you watch out for? Bleeding. So watch out for any signs of bleeding. If your patient is bleeding, if your patient is suspectedly bleeding, how do you position your patient?
feet up.
Feet up, feet down.
Up, feet down.
Feet up, feet down. Again, if you're suspecting bleeding, it has to be feet down. Feet down, Trende, reverse Trendelenburg.
Huh?
Suspicion of bleeding, Trendelenburg, reverse Trendelenburg.
Trendelenburg, it's...
What's Trendelenburg? Feet up, feet down.
Feet up.
Feet up. So it has to be reverse Trendelenburg. Feet down. If you're suspecting bleeding, it has to be reverse Trendelenburg. If you have confirmed that the bleeding is coming from the vagina, it's coming from the surgical site. So what you need to do, it has to be Trendelenburg. Why Trendelenburg? To bring the circulation back into the areas where it's needed, and it's more on the upper extremity. So if you have confirmed, it has to be in the Trendelenburg position. Now, how would you know that the patient is bleeding? Check the vitals of your patient. Vitals of your patient, blood pressure will go,
Down.
heart rate will go,
Down.
respiration will go
Down.
What about the
up, and they will complain of shortness of breath.
what confirmed?
If you're confirmed, it has to be Trendelenburg position.
What is confirmed? I didn't get that.
Once the bleeding is confirmed that it's coming from the vagina, then you have to put the feet up to promote venous return to give more blood to the brain. Now, what else can let you know that the patient is suffering from bleeding? Blood pressure is going low, heart rate is speeding up, respiration is going up to catch up all the oxygen because there's rapid heart rate, and if the patient keeps on doing that, the patient will develop shortness of breath. Now, if bleeding, of course, continues without you knowing it, the patient will now have a decreased O2 perfusion to the different parts of the body. The one that is greatly affected would be the one that receives 1/3 of the cardiac output. And what is that? Brain. So if brain doesn't get enough blood supply, then this will cause your patient to have altered level of consciousness. What's the first sign of an altered level of consciousness?
No.
Okay, it's your restlessness, disorientation or restlessness. So once your patient's having decreased O2 perfusion to the brain because of severe bleeding, they become altered. Alteration will be on the latter stage of shock. So if this is a latter stage of shock, what do you see? Restlessness on your patient. So watch out for bleeding. What else do you have to watch out for your patient? Risk for infection. How would you know your patient is having risk for infection? Temperature is going up. What else? There is discharge coming out. So you have to watch out for discharge coming out. A foul-smelling discharge that is coming out. What else do you have to tell your patient? You have to prevent urinary retention. You have to prevent urinary retention. Now, why do we have to prevent urinary retention? Because if bladder becomes filled up, what does the bladder do? It tends to stretch and pull some connective tissue, and since bladder is somehow connected to the reproductive system, can that cause the incision to tear? Yes. So to prevent urinary retention, it is expected that post-op your patient will also have Foley catheter. To which disorder do you expect your patient to also have Foley catheter after a procedure? To which type of disorder do you expect also your patient to have Foley catheter right after a procedure? We have discussed it yesterday, like around 5:12 p.m. What is that procedure that also requires Foley catheter right after that procedure? What is that procedure? The last part. What's the last part that we have discussed yesterday? Prolapse. The cystocele, rectocele. Now, if the vagina is going out, if the bladder is going out into the vagina, the rectum is going out to the vagina, uterus is going out to the vagina, what do you need to do? Surgically repair the defect in the vaginal wall. What do you call that? Colporrhaphy. After colporrhaphy, what is it that you have to insert? Catheter, because you don't want the bladder and the rectum coming out again because of a strong force coming from a heavy structure of the urinary and reproductive system. So same here in your patient who has hysterectomy, it is best advised to have a Foley catheter as well. Now, of course, you also have to prevent fecal retention. You have to prevent constipation. Why do you have to prevent constipation? Because you don't want the patient to bear down. So to prevent constipation, of course, expect your patient will benefit from laxatives. So again, we don't want constipation because we don't want the patient to bear down. So if you don't want the patient to bear down, give me instances that would cause a patient to bear down. Okay, so you don't tell your patient avoid lifting. Avoid lifting more than, now this time make it a little bit lesser, 5 pounds. So again, no bearing down for your patient, meaning you don't let your patient lift more than 5 pounds, because lifting more than 5 pounds can cause your patient to bear down. Bearing down can cause the tissues to become the lacerations of the incision. So you don't bear down more than 5 pounds. Now what else? Tell your patient not to have sexual activity for 4 to 6 weeks. No sexual activity for 4 to 6 weeks. Now again, any reproductive issues, when sexual activity is not advised, you always tell 4 to 6 weeks. If you're asked to choose between 4 and 6, you answer 4 weeks. So again, any procedure that affects reproductive organ and sex is not advised, and if it's asked how long, it has to be 4 to 6 weeks. When you're asked to choose between 4 and 6 weeks, you answer 4 weeks. Now, but the latest answer now for NCLEX, if the woman had delivered and the woman would ask you, when will I resume sexual activity, the best answer would be, if you and your husband are comfortable doing so, then you can resume sexual activity. So it's how soon they are prepared to perform sexual activity. Before, the answer is, how soon should you resume sexual activity after delivering a baby? Answer before was 6. Then it was changed to 4 to 6. Then now the best answer is 4 weeks. But the latest one that they have known that the answer to NCLEX would be when the man and the woman are ready to do so, they can engage into sexual activity. So when they're ready. So if they're ready in 1 week, then let them do that. So no sexual activity in 4 to 6 weeks for a patient who had hysterectomy. Okay? So that's no sexual activity for 4 to 6 weeks. What else? You have to avoid DVT. Why? Because you're losing hormones. So you have to avoid DVT. How do you avoid deep vein thrombosis? Patient needs to lay down. Patient is not really moving a lot. So you have to avoid DVT. So how do you avoid DVT? Early ambulation to your patient, right? What else? Wear stockings. What kind of stockings? Knee-high? What kinds of stockings do you wear? Knee-high?
Huh?
Knee-high stockings? Knee-high, do you advise wearing of knee-high stockings? No, anything that can occlude the blood flow to the lower extremity? No. What kind of stockings do you advise? Anti-embolic stockings. The TEDS hose, the thromboembolic device, anti-embolic stockings are the one advised to your patient. Now, can they allow long trips? Can you allow long trips to your patient? Now, for as long as they have rest areas that they have to stand, walk, circulate their blood to the lower extremity, that's fine. Now again, you have to let the patient have an early ambulation, wear an anti-embolic stockings. You have to advise the patient to have massage of the area so that they will prevent DVT formation, because DVT is a very high risk in patients who underwent hysterectomy. So these are your consideration if your patient is having hysterectomy. Let's go to the next type of cancer, which is the cancer of the breast. Let's finish cancer of the breast. So later this afternoon, we'll just discuss male's reproductive disorder and infection. Then you're gonna go home. So let's start with the cancer of the breast. Now for the breast, let's just briefly describe. Let's just briefly review what's going on, or what's the normal anatomical or pathophysiology of our breast. Now our breast is composed of what? Where do you see where's the exact location of our breast? It's on the pectoral muscle. So breast is on the pectoral muscles. Now, it is attached to the pectoral muscle. It's on the chest. Now, that's the reason why for some guys, they look like they have a chest. It's because their pectoral muscles is full of fats. So again, our breast is attached to our pectoral muscles. So if it's attached to our pectoral muscles, fats on the pectoral muscles can make the breast looks bigger. So in male, if you see breast in male, it's not really breast engorgement. It's actually their pectoral muscle is having fat deposit. That's why they look like they have a breast. Now, pectoral muscle. What else? Your breast is composed of adipose tissue. Your breast is composed by adipose tissue, and inside this adipose tissue, you would have these lobes. What do you call these lobes? The lobes inside the adipose tissues of our breast. So this adipose tissue would usually have your the ductal lobes that is actually the one that produces milk. Your ductal lobes that produces milk. Now, these lobes inside our breast is separated by adipose tissue. So, that's the reason why the adipose tissue is the one that determines the size of the breast. Adipose tissue is the one that will determine the size of the breast. The lobes, the 15 to 20 lobes found inside our breast is the one that will produce the milk. The 15 to 20 lobes found inside our breast is the one that is capable of producing milk. Now, if this 15 to 20 lobes contains milk-producing cell, then this 15 to 20 lobes is actually connected to a lactiferous duct. This is actually connected to a lactiferous duct. From the word itself, it's lactating duct. So it's composed of a lactiferous duct or a lactating duct which is connected to the nipples. Now, the lactiferous duct is connected to the nipples. Now, this nipple is made up of smooth muscle cells. Our nipples are made up of smooth muscle cells. So, in short, since it's made up of smooth muscle cells, our nipples is also capable of contracting and relaxing. So, since our nipples is made up of smooth muscle cells, it's also capable of contracting and relaxing. What else? Our nipples is also containing nerve endings. The nipples is also containing nerve ending. So, if it's containing a nerve ending, nipple has a direct signal going to our brain. So, that's why nipple stimulation stimulates the brain that nipple needs something, and what does usually is occurring, it would be your two hormones. Once the nipple has been stimulated, there will be two hormones that will be released. Once it's nerve ending and it has been stimulated, two hormones will be released. What are those two hormones? First is oxytocin. Next hormone will be the prolactin. So again, once the nerve endings has been stimulated, this nipple nerve ending will send signal to the brain. And the brain, since it's coming from the nipple, the brain will release a specific type of hormone. Now, it will release oxytocin and prolactin. Now, what's the purpose of that? The oxytocin is the one that will promote let-down reflex. Oxytocin is the one, with regards to the breast, is the one that will promote let-down reflex. Prolactin is the one that will promote milk production.
What is let down?
Okay, let's go over that. Now again, nipples are made up of smooth muscle cells and nerve ending. Since it has nerve ending, at the end of it, nerve ending, it has a direct connection to the brain. That once it's stimulated, the brain knows that the nipple has specific needs. So the brain will release two hormones. The two hormones that it will release, oxytocin and prolactin. Prolactin enhances milk production. So all of those lobes will start to be filled up with milk. Now, the milk being filling up the lobes will go and flow into the lactiferous ducts. So, once it goes to the lactiferous duct, it will be ejaculated in milk. So, the more you're emptying the lactiferous duct, the more you're entering the lobes, the more you're stimulating the brain to fill up again the lobes. Now, what else? The nipple stimulation also releases oxytocin. Now, what is that oxytocin? It causes the letdown reflex in breast. So, which means, if you are actually having that oxytocin, if it starts to build up, once the milk has been filled up, once the lobes has been filled up, it will let you know that it has been filled up already, that resulting to milk pouring out from the breast of the mother. If you have that belief that whenever you just gave birth to a kid, and you're a lactating mom, your kid is left at home, you go to work or school, after 3 hours, your breast is leaking out milk, that's the letdown reflex. Grandmother says that it's an indication that the baby is already hungry. That's not true. Why? There's no signal from the mouth of the baby to your breast. The reason behind that is because of the oxytocin that was released when you breastfed the baby. The oxytocin will give you a signal if the lobes are already filled. If the lobes are already filled, the oxytocin causes it to pour out. That's your let down reflex. So that's your oxytocin. That's the purpose of your oxytocin. That's why be very specific when they're asking you for the purpose of oxytocin. As we have discussed before, what's the purpose of the oxytocin during labor? Expel the baby. What's the purpose of oxytocin after labor? Prevent uterine bleeding. What's the purpose of oxytocin after labor to the baby? It's to promote let down reflex. It to have a successful breastfeeding. Now,
Wait, I'm sorry. Before labor?
Before labor, during labor, it's because you want to expel the baby. After the labor, for the mom, you would want to prevent uterine bleeding. After labor, for the baby to achieve a successful breastfeeding. Because what will keep your lobe filled with milk is continuous nipple stimulation. And continuous nipple stimulation after birth is done through breastfeeding. Now, so again, the lobes contains milk, and once this milk has been filled up, you just have to empty it. Once you empty it using the nipple stimulation, sucking of the nipple, it will stimulate the brain to again produce prolactin. Yes?
Why is it that some women are not able to produce milk? Is it because they lack oxytocin, or is it the ducts?
There's no real reason why you would have to stop producing milk. There are studies showing why, but there's no reason why a woman would not produce milk. Now, women have their own reasons. Sometimes they would say, I guess my baby's not getting enough. That's why I have to stop. I have to give him extra milk. Breastfeeding is painful. It's really painful, especially on the first few days that you're trying to get used to it. Especially when the baby has a very good sucking reflex that the nipple is already starting to become lacerated. It's hard to breastfeed with a lacerated nipple. If you're capable of tolerating all of those pain, you should be able to produce sufficient amount of milk. But again, it depends on the women. Some women doesn't have very good pain threshold, that a simple pain would cause them to stop. Of course, if they stop, literally, they're telling the brain, I cannot do it anymore. Brain might be affected, causing the brain not to send signal of prolactin. Breast milk production will stop. So stress might be a cause. The willingness of the man might be a cause. The pain threshold of the man might be a cause. And the sucking ability of the baby might be a cause. But technically, all women should be equally producing the same type of milk. It's just how you stimulate yourself. Okay? Now, smooth muscle cells, before I go that one. Now, nipples are made of smooth of muscle cells, so it tends to contract and relax, so which means smooth nipples can also erect and relax. So, who is more deserving to say that I am having erection? Is it the male or the female? It's actually the female. In male, they will just have penile erection, but in female, we have two areas of our body erecting, and that is our clitoris and nipples. So nipples are also capable of erecting, and this is also erect when physiologically stimulated to sexual activity. Now, what else? If women says, I don't have milk because I don't have breast, would that be true? Does the size of the breast determines the ability to breastfeed? No. Again, the size of the breast depends on the adipose tissue.
But some women don't have nipples.
Let's see. Let's figure that out. Adipose tissue determines the size of the breast. Nipple stimulation determines the ability, the success of the breastfeeding. So in short, since all women, big or small boobs, they would usually have the same nipple, so the ability to breastfeed should always be equal. Now, between those women who have large breasts and small breasts, which between the two becomes more successful in breastfeeding? Those with a bigger one or a smaller one?
Smaller one.
Give it to the smaller one. Smaller one are usually the ones successfully performing breastfeeding. Why? It is because if you have most of women who have big breasts would usually have an inverted nipple. Why? Because of the big fatty tissue, it kind of covers and indent their nipples. The fatty tissue causes the nipples to invert. So they would usually have inverted nipples. Now that inverted nipple affects the baby's sucking ability. So if this is an inverted nipple, this is a breast, and you have an inverted nipple, the baby will have a hard time looking for that nipple. And if baby becomes hungry, what will the baby do? Cry. Of course, the mother cannot take that baby crying, so what do? Give the bottle feeding. So if they do bottle feeding, lesser nipple stimulation, they would stop breastfeeding. Compared to women who is not well blessed with estrogen that will promote adipose tissue production or enhancement, what will happen? All they have was nipple, right? So only nipple, no adipose tissue. So baby can suck well the nipple because that's all they have. So if the nipple is well sucked, nipple is well stimulated, the mommy will produce a lot of breast milk. So women who have lesser breasts would usually be the one having successful breastfeeding. But don't worry, for those who have been blessed with a lot of estrogen resulting to an increased size of their breast, do not worry. You might not be a successful mother, but definitely you'll be successful wives. So your future depends on the size of your breast. If your breast is small, you'll be successful mother. If your breast is big, you'll be successful wives. Yes.
Usually women, they have a lot of kids, they have a big breast.
A lot of kids again. There's a lot of things with that, a lot of kids. I'm wondering why. Say that again.
Usually women who they have a lot of kids, well, they go a little overweight a little, sometimes not, but usually they have a big breast. And they have a lot of milk, and I see, bang, I didn't breastfeed. I didn't breastfeed my kids because I want to have a nice breast.
Okay. See, that's one thing. So
they just putting the bottle and filling it up.
So again, the reason why we would produce milk is adequate stimulation. So it really doesn't, the size doesn't really matter. But who usually becomes successful are the one with lesser size because of the nipple protruding right away for easy sucking of the baby. Okay, so the size of the breast, so big and small. Now, what else? What would enhance milk to come out? Warm compress. What else? Manual evacuation and continuous sucking of the breast. So what will enhance milk to come out? Continuous sucking of the breast, warm compress. So warm bath helps in milk production because it promotes good dilation of the blood vessels, and manual compress of your patient. So that would be your lobes. Now, with regards to big breast and small breast, which between the two is prone to breast cancer? Who is more prone to breast cancer, the small one or the big one? Give it to the big one, right? The breast cancer are, oh my God, you're making me laugh with your expression. She was like, okay, so those with big breasts are the one at risk of breast CA. Now, because those with smaller one, what's the reason behind? What's the earliest way for us to determine breast cancer formation? Breast self-examination. So the size matters again. Look, breast self-examination, you have to check if there is overgrowth in your breast, right? You usually do that 7 days after menstruation. Now look, if you have small breasts, when you take a bath, even if it's not 7 days, when you try to scrub yourself, you would easily determine anything that is overgrowing. No, for some reason, I have bigger size of breast on this part. So if you have flat breasts, then you would easily palpate any overgrowth, right? Compared if you have big breasts, what will happen? You would have, again, a big hump in there that once there's an increased size on that area, you would not easily detect unless you perform deep palpation. So that's the reason why, before you diagnose cancer in those patients who have big breasts, it would be on a later stage. On those with a smaller one, then you would usually easily diagnose that because on a little change, you would easily diagnose. So, to determine if you have breast cancer formation, what's the earliest way to determine that? Again, that's your breast self-examination. So breast self-examination is the cheapest way of determining early cyst formation. When do you do BSE? 7 days after menstruation. So that the estrogen level will be at its lowest. It will be going at its lowest stage. 7 days after menstruation or 1 week after menstruation. But if the patient is already 75 years old, don't tell them, oh, you have to do it 7 days after your menstruation. You will have a hard time teaching this patient because they have to wait for the menstruation to come. If it's 75-year-old, 85-year-old, had hysterectomy, what do you advise them? Do not perform any do not perform any BSE because you're not menstruating anymore? No. What do you advise them to do?
Monthly, same day.
Monthly. It has to be done every month, preferably at the same day of every month. So if you choose every 7th of the month, every 5th of the month, then you have to do it every 5th of the month. Now, BSE is the one that will early determine cyst formation in the breast. But the one that will see cancer formation or for early formation of cancer will be your mammography. So mammogram is the one that will early detect cancer formation. The one that will early detect cancer formation, even if it's on the earliest stage, will be mammography. You would see lumps in BSE, but you would visually see the cancer formation, early cancer formation with mammography. To whom do you advise mammography? Or how frequent you should have undergo mammography? Annually, right? Annual mammography is advised to those patients who goes to the high-risk stage. Who are the high-risk patients?
Menopause
Menopause women. What age?
40, 45.
40 years old. Once you reach 40 years old,
Depends, maybe 35.
once you go 40 years old, then you have to have an annual mammography, even without a symptom of cyst formation. Once you go 40 years old, you have to have an annual mammography. Even if you don't have cyst formation, you're not palpating anything, at 40 years old, you have to have an annual mammography. But before you have an annual mammography, you have to have a baseline. So you will have a comparison, just like an x-ray. If you will be having an x-ray today, most of the time the doctor will say, did you have a previous x-ray? I would want to compare if there was a change. So you have to have a baseline, and baseline should be done between 35 to 39 years old. So once you're 35 to 39, you have to choose a time, most likely it's 39 years old, to have a baseline mammography so that you will be able to compare changes in your breast once you go to the high-risk stage. What are the things that you have to tell your patient who is about to have mammography? Never use any deodorant, lotion, oils, perfume prior to the procedure. Why? All of this can cause alteration in the result and burning sensation to mammography. Again, before mammography, never allow your patient to use lotions, cream, deodorant, perfume near the area. Why? Because all of this can alter the result, especially the powder and cream. It can alter the result. Now, what about the perfume? Anything containing alcohol can cause burning sensation during mammography. If the patient asks you, is mammography painful? What's your answer?
Yes.
Yes. You answer yes. It is really painful. Now, you have to warn your patient, it's really painful. I know, I told you, you never tell your patient it's painful, but this is an exception to the rule. All other, you just say, oh, this will cause discomfort. Lumbar puncture, is it painful? Yeah, it will cause you discomfort. Is biopsy painful? No, it will just cause you discomfort. But if it's mammography, let your patient know, yes, it is painful. Why? You will be squeezing the breast to its maximal level to make sure you are seeing all the breast tissue. So if this is the breast, there are two plates surrounding this one, and they have to compress it as hard as it is to make sure all tissues inside the breast is well seen by mammography. So the bigger breast that you have, the more pain you will have. The lesser breast that you have, the lesser pain that you will have. So that's the advantage of our big breast and small breast. Not really. It will just be during the squeezing stage that it will cause pain. Squeeze up, squeeze down, lateral sides. So that's how they do it. Okay? So mammography is painful because of the squeezing. Yeah, so you just have to choose breast pain during mammography or breast pain during breast cancer. So you just have to choose between the two. So that's painful. It's painful. So mammography, so this will be the one that will early diagnose your breast cancer formation. Now, there are different types of growth in the breast. You have fibrocystic breast. Say that again.
I never go for
Well, if you're high risk, then you have to go.
I'm not high risk.
My
mom doesn't have it.
No, you're considered high risk if you're more than 40.
I'm over 21.
Oh, that's what I'm saying. If you're if you're on the high risk stage, you have to make it.
Isn't it genetic?
Say that again.
Go doctor. Isn't it genetic?
Yes, all cancers are genetic.
So, that's why I don't know.
Okay. All right. Fibrocystic breast condition. Fibrocystic breast condition is a hyperplasia and cystic formation in the mammary gland, but this is not cancer. It's just a fibrocystic cyst. So again, fibrocystic breast condition is a hyperplasia, but it's not considered metastatic. It's just a multi-cyst formation in the breast that would cause you to palpate cysts that are well differentiated, tender, moving freely, and often bilateral. So again, fibrocystic breast condition are actually multi-cyst formation that is palpated on the breast of a patient that is soft, well differentiated, meaning it just have same structure, usually tender, it's painful, it's movable, and it's found on both breasts. The reason behind this is because of the behavior of our breast tissue. Now again, if you still remember the behavior of our cells, if our cells is not anymore needed, it has to degenerate. So in short, the tissues here in our breast, the breast tissues compared to the endometrial tissue behaves differently. Now, in our uterine tissue, once it degenerates, what does it do? Slough off, you bleed. You will have menstruation. Here, when the breast tissue has been enlarged because of the influence of what hormone? Estrogen, right? Estrogen causes the breast tissue to enlarge. Menstrual cycle, estrogen thickens uterus, breast becomes enlarged. But of course, once the egg cell disintegrate, estrogen decreases. What happens to the breast tissue? It will start to degenerate. Now here, once breast tissue enlarges because of the hormone estrogen, once the estrogen becomes low on the menstrual phase, your breast tissue will now have a natural cell death. You call that your apoptosis. So that's the reason why for some time, you see, my bra fits so, it's like my bra is so tight for this week. And then the following week, you'll say, I guess my bra is already have loosened already. It's because the reason why it's tight, your estrogen level is very high right now. Now, once you go to the luteal phase, then estrogen goes down, your bra would look like it's loose. Now, what's the reason behind? The breast tissue that was enlarged during the estrogenic phase has performed a natural, normal cell death. You call that your apoptosis, wherein the tissue would normally die. Now, once the tissue dies, it should not have any effect. It will just have a normal cell death. In a patient who developed fibrocystic breast condition, this tissue that has died, has been eaten by their scavenger cell. Remember the scavenger cell in your immune system? The scavenger cell is a type of T cells, and what does it do? It doesn't fight, it eats the microorganism. It eats the dead tissue. So again, since you have a dead tissue in a normal person who's not developing this, the dead tissue will just be reabsorbed into the circulation, lymphatic tissue, then it will be discarded. In this patient who develops this, the dead tissue is being identified by our T cells. Which type of T cells? The scavenger cell. T cells have killer, the helper, the scavenger. Killer T cells are the one that fights. Helper is just the one that will help. Scavenger is the one that will eat. Now, this scavenger cell feeds on this dead tissue. So once they start to eat, since they are activated, the T cells results to an inflammatory response. The scavenger cells causes an inflammatory response. So once the scavenger cells perform inflammatory response, this is the reason why your patient will experience pain and swelling. So that's why they will have breast tenderness and pain on that area.
Does
Yes.
that make it autoimmune?
No, not really. No, again, once the tissue dies, the scavenger cells eats, and since the scavenger cells is our fighting mechanism, once it activates itself, it tells the body you have to perform inflammatory response in this area. So the inflammation causes swelling causing pain. So that's why they will have tenderness on the brain, and they will usually have swelling of the brain and pain on the brain. Now, pain on the breast. Now, inflammation. The inflammation, what's the goal? What's the goal of the inflammation? Healing process. But healing process involves scar formation. So this scarred formation is the reason why you will be able to palpate fibrotic tissue. So you will be the patient will be able to palpate fibrous formation in that area because the area that has inflamed has scarred, and that result to fibrous formation. The fibrous formation is the reason why if the patient tries to perform BSE, they will feel lumps on their breast. These are just scarred fibrotic tissue that resulted from the inflammatory response due to the scavenger cell activation. So that's your fibrocystic breast condition. They will just have this symptom every now and then, on and off during their menstrual cycle, all because of the breast enlargement. They would stop this if the estrogen decreases its production. Now, what's the management? Eliminate with the methylxanthine. The methylxanthine will try to eliminate the scavenger cell production. Vitamin E aldanazole will just help them prevent the symptoms. So eliminate the medical management will be methylxanthine. This will just eliminate the enlargement of your patient. Danazole, vitamin E will just help in the skin integrity of your patient. So this is just something that they will just have to deal with their life. So that's your fibrocystic breast condition. Now that will be your patient who is suffering from FBE or fibrocystic breast condition. Now, once the breast becomes infected, you call that your mastitis. Once the breast becomes infected, that's what you call mastitis. The type of mastitis that you would usually see in a patient who has fibrocystic breast condition will be your chronic mastitis. The type of mastitis that you would usually see in a patient with fibrocystic breast condition will be your chronic mastitis. Mastitis is the inflammation of the breast. We have two types, the chronic and the acute. Again, if there is always fibrocystic breast condition, this predisposes patient to infections of the breast. Once the breast becomes infected, you call that mastitis. There's two types of mastitis, acute and chronic. Based on the terminologies, if it's acute, it's just suddenly occurring. If it's chronic, it has been there for a while. So the one that is common to patient with fibrocystic will be your chronic mastitis. But just to differentiate the two, acute mastitis is an acute bacterial infection of the breast. Now, breast becomes tender, inflamed, and engorged just because of the inflammatory response. Now, how do you manage this patient? Keep your breast clean. How do we clean our breast? Or the areola of our breast? Water and soap. Antibacterial, non-hypoallergenic, no soap. How do we clean our breast? The areola part, the nipple, how do we clean it? Water with soap, water with hypoallergenic soap, water with antibacterial soap, just water. Water. Why? Because our nipple has Montgomery glands. The bumps on our areola is the one that produces as oil. The oil that is produced has an antibacterial effect. So if you put soap in there, then you're taking out the oil. If you take out the oil, you take out the natural way of removing the dirt in your areola, in your breast. So that's the reason why you never put soap in your on your areola, specifically on the dark portion of our breast, which is the areola. Because the areola has Montgomery glands. What are those Montgomery glands? These are the small bumps in our areola. That small bumps is the one that produces oil, and that oil has an antibacterial effect. Now, keep the breast clean with just water. Application of warm packs to improve blood flow to prevent inflammation. Support will be well-fitting bra, and systemic antibiotic or oral antibiotic will be given to your patient with acute mastitis. Now, mastitis can sometimes happen to, these are the one happening to those mothers who are breastfeeding. The nipples crack, baby's mouth is dirty, the microorganism goes inside. This causes the mommy to have the infection. Now, what will further cause the mommy to have infection? If the mommy won't breastfeed. Why? Milk will be the food for that microorganism that has penetrated the nipple of the mommy. So again, baby sucks very good. The baby crack the nipple. If nipple is cracked, it's an impaired skin integrity. Baby's mouth is dirty. Baby sucks. Microorganism goes into the nipple. Microorganism goes into the lactiferous duct. Since it's full of milk, will it grow? Yes. So what do you advise the mommy? Still encourage breastfeeding. If the mommy cannot withstand the pain, then they might use the nipple shield. If the mommy cannot still handle the pain, you have to advise the mommy you have to manually evacuate the milk, because for as long as the milk is there, the microorganism can grow because the microorganism feeds on the milk. That's why they benefit on the antibiotic. Yes.
But if there's microorganisms in the milk, doesn't it hurt the baby to feed the baby?
Well, the microorganism just stays. The microorganism is just feeding on the milk, which means the microorganism just getting the milk. They're not actually going into the milk. Okay, it's just feeding on the milk. Since there is milk, so reabsorption, so some of the milk leaks out to the microorganism, to the site of the tissue. So again, systemic antibiotic will be the benefit for them. Now, for chronic mastitis, it's of course because of fibrosis and cysts. It's tender, but it's usually have same management for your patient who has acute mastitis. It's just most commonly seen in fibrocystic, not because of milk, but the reason why you will have chronic mastitis is because of the dead tissue. The dead tissue enhances growth of microorganism. It's 12, right?
Yes.
It is. And so I'll just discuss the cancer of the breast after the break, and then we'll discuss the breast cancer after the break, after your lunch, and then we'll discuss the male's reproductive system, and then infection, and then you'll go home.
What time is it?
Be back 1 o'clock. So 12, yeah.
How many pressure will be
50.
50?
Mm-hmm. Shoes. I haven't copied the syllabus. Be back 1 o'clock. Mm-hmm. 1 o'clock.
We're going to come back in 1?
1 o'clock.
So the cancer of the uterus, it's abdominal hysterectomy most of the time, right?
Yeah, because you have to open it. Yeah, you have to open it, remove everything.
Isn't it cold here? It's cold.
I can never understand. When is it cold?
You know, you would be considered absent for that.
Why?
Because if it's 2 hours or more, then you're going to be considered absent. If it's less than 2 hours, then you would be considered tardy.
What about
If you leave after the first break, that's fine. It would be tardy.